Okay, so looking at a picture of my foot, I shouldn't tell you it's my foot, but I have outlined the medial border or the border of my medial malleolus and indicated my apex with a star and then drew a line across the distal tip very poorly. And then mark the border of my navicular tuberosity and start it. Again, be sure you are very familiar with the surface anatomy. Do this exercise on yourself or on someone else especially would be better, just to make sure that you understand exactly where these are and you can feel them. It's very, very crucial when you are doing a casting and making your marks that you know right where these are. So the distal tip, be sure you get a good palpation on that because you will have to use these landmarks for measurement. You'll have to do apex to the ground, tip of the malleolus to the ground, navicular to the ground, things like that. So be sure you know those measurements and those anatomical locations very well. All right, so I took a tape very, very poorly and measured 2.5 centimeters down and then 2.5 centimeters over, and Newman's pretty much right for me, so he told me I am like everyone else. 2.5 centimeters inferiorly and then 2.5 more distal, and you will find, ta-da, the navicular. Alright, so you might be saying, well, geez, Cass, who gives a care about 2.5 centimeters inferior and distal, blah, blah, blah. Well, let's say you had an appointment with a patient and you cast them and your indelible mark didn't transfer and your patient's already left and you don't know what to do, they can't come back, blah, blah, blah. You still got to make relief for it somehow. So this might be a good estimation if you are unable to see it in your cast. And if you aren't able to bring your patient back, it can give you a rough idea of where that navicular might be. However, that's no excuse. You should always be sure to find it on your patient if possible, and make sure that you always mark it well. So, if you get a minute, do it to your navicular and go ahead and measure that out. That value and more information on that is found on page 577 of the Newman kinesiology book, okay? Alright, so we finished the navicular. Let's go ahead and move on and look at the cuboid. So the cuboid is going to be right here, obviously. Alright, so obviously it looks like a cube, and the pretty just only real significant feature on the surface of it, just looking at it, is that it has this groove right along the inferior and lateral portion of it. It's not too defined here, but you can see it a little bit. That is for the peroneus longus tendon. It's going to come right around here and insert down on the base of that fifth. So, one thing I forgot to mention before, which I know you guys have already talked about, and I talked about it with you a lot last semester in the intro to P&O class during the orthotics lecture, was that there are two grooves along the calcaneus as well. The one that I can't say very well, sussum tactum tali groove, and then the peroneal groove. So, we'll just call it the ST groove. It's going to be along this medial portion, right in here, and then the peroneal groove, again, is going to come down here, and some will wrap around here, and wrap right around there. So that peroneus longus is going to come down this way. Alright, so we have those two, and do you remember the name of that modification that we can do? I don't remember if we talked about that too much. That's called a Carlson modification, where you take your positive model and you carve in here. It's easier if you look at the planar surface of it. But you'll dig in on those two areas, and that will allow you to effectively control the hind foot a little bit better, and typically this is used in a UCBL. So we've already discussed this, and I'm pretty sure you guys had some questions, test questions or something like that, on how to have hind foot control. But yeah, that's it. So we're going to cut in here. Not cut in, but, put a modification right in here so that we can really hold on to this calcaneus and stabilize this hind foot. Okay? Alright, so we got that taken care of now. Let's go ahead and look at our cuneiforms. So our cuneiforms are medial, our intermediate, and our lateral one. So if we get a little closer to them, real quick. An important thing to notice is that all three of them are articulating with the navicular. So as the calcaneus pushes against the talus, and there's some other things going on, but then the talus is going to push against the navicular. And since the navicular articulates with all three cuneiforms in their more proximal portion, it's going to drive each of these into these metatarsals, right? So it's going to push into each of them and then drive the rest of the metatarsals on as well. While our good friend cuboid is over here pushing on the base of our fourth and fifth metatarsals to drive it. So there's ligaments that connect all of these together, but that's pretty much the main almost flow, I guess you can say, of how each one dominoes and affects the other one. Okay? Alright, so only other thing about the cuneiforms is that they are wedge shaped, so you can see that they are a lot more narrow down at the bottom and a little thicker up here at the top, and we'll talk about the purpose of that later on when we talk about the muscles that attach and the plantar surface of our foot a little bit more. Alright, so now that leaves us with our forefoot, which, let's back this up, consists of, yep, you guessed it, our metatarsals, which are right here, and then our phalanges, our proximal, and our distal, and our middle ones on the second through fifth. So one thing to note is that we have, especially in orthotics, we talk about the array in a foot. So a ray is considered, or one ray in the foot consists of one metatarsal bone and its accompanying phalanges. So if we look at, let's just say the second ray right here, which is typically the longest ray in the foot, it has other anatomical significance we'll get to, but this second ray would be the second metatarsal, second proximal, middle, and distal phalange. Okay, so fifth ray, fourth, and so on. Alright, so looking at the structure of our metatarsals a little bit more in depth, we know that the metatarsals have a base right here that articulates with the tarsal bones, the shaft, and then the convex head at the distal end. So frequently we talk about met heads, and this is the area we are referring to. Your patients will probably call this the ball of their foot, but it's going to be this area right in here. You always need to make sure that you are able to palpate each of these joints between the metatarsal and the phalangeal so that you know exactly where those are. Different trim lines, especially for ankle foot orthoses, can affect your treatment basically on where you place the end of your foot plate. If you place it all the way at the end of the toes or in the sulcus region between the distal part of the toes and the metatarsals, or if you bring it past these metatarsal bones right along this edge. So the different trim lines will affect it, but you have to have these marked on your cast and make sure that you take those into consideration when you're doing your trim lines, okay? Alright, so let's go ahead and turn and look at the first metatarsal bone right here. If we look at the plantar surface, we can kind of see in this picture two small sesamoid bones. So the first metatarsal has two sesamoid bones that are in the tendon of the flexor hallucis brevis. Any sesamoid bone in the body, like your patella or your pisiforum, these all provide some type of lever or pulley system for that tendon. So we have some patients that come in with inflammation of this tendon, of the flexor hallucis brevis, and have pain in this area due to friction within these sesamoid bones. So pretty much they will experience the most amount of pain when this is in contact with the ground, because as our foot becomes like a rigid system for push-off, this is going to push into the ground a little more, and it's going to be painful for the individual that has inflammation in this area. Alright, another thing to look at is that the shape of both the metatarsals and the phalanges are a arch type shape, and we'll talk more about arches when we look at the foot as a whole. But arches help distribute the weight and provide a more optimal and appropriate weight-bearing surface. So our first metatarsal is going to be typically the shortest and the thickest. It's giving the fifth run for its money, but it's typically the shortest and the thickest. It is producing a lot of weight, a lot of force and strain is having to go through this metatarsal. So that one is going to be very thick, and then the second and third are going to be the next, and they are tied very, very closely. It's not a good representation in this picture, but they're tied very closely with these cuneiforms and attached rigorously with a lot of different ligaments. The only other really surface anatomy that you will deal with frequently is going to be the base of this fifth metatarsal. It has a styloid process, which, like the navicular, again, is a really important landmark to indicate, because when taking a cast, its close location to the surface makes it an area that the skin above it is susceptible to breakdown. So you definitely need to make sure we have this marked and relief built in for that. Alright, so when we look at the phalanges, we have again a proximal, middle on the second through fifth, and then distal portions on each of them. The main thing to note is that the phalanges pretty much have the same structure as the metatarsals. They're going to have a wide, I guess, base, and then the more narrow shaft, and a more convex head at the end of them. Like I said before, each of these bones are going to drive the next in order, and we'll talk a little bit more about the joints and the how the structure and function are so intimately tied to each other. It's really hard not to talk about one without talking about the other. But again, like this is an arch shape, our phalanges work or are formatted in an arch shape to help distribute that weight. So we just finished looking at the foot. Again, we have our calcaneus, our talus making up the hind foot. And so we are able to control a lot of what the rest of the foot does in our orthotic management by controlling this hind foot. And our midfoot is comprised of our cuboid, our navicular, and then our three cuneiform bones, right? Our forefoot, again, is comprised of the metatarsals and all of the phalanges. Okay, so that comprises our foot bone overview, and now we are going to go and talk about the arches of the foot.